Okay, this is part 6 of the crash course in teaching diagnostic reasoning. We're going to talk about how and when to use Bayesian reasoning. So let's talk about the two major types of reasoning. This is going to revisit some concepts, but some are new here. So first, there's normative reasoning. This is the ideal mode of decision making that maximizes yield and utility. And here's an example here using Bayes' theorem. Ideally, if the mathematicians, the utilitarians would say, we would get a patient complaint, we would start to use different signs and symptoms with known probabilities that would map to different refined probabilities of disease and ultimately arrive at a prioritized differential diagnosis that was linked to those probabilities. We could do Fagin's nomogram ad nauseum and do that over and over again, and that would be the idealized way of reasoning. That would be bias-free, and it would be a very analytical, computational way of doing it. We've also talked about scripts, right? This is more of a descriptive mode of reasoning. This is actually how we make decisions, right? We have system 1 thinking, system 2 thinking. We use intuition, heuristics, biases that come in that help us solve cases. We might do some analysis and reframing and reprioritization. And we're often looking at patients and seeing how well does their presentation match with illness scripts in my brain and my long-term memory. So this is really typically how we're often reasoning. This is the normative form of reasoning. This is the way we'd ideally do it if we had infinite brain power, infinite ability to do math. So the normative approach includes a value judgment. It's i.e. how we should think. That's what normative means. And it's stated that way because really that would be the most bias-free way of arriving at a diagnosis. And that's what Bayes sort of proposed. It's a mathematical approach that we consider pretest probabilities and explicit probabilities linked to different findings. It's a very system 2 way of thinking though, right? It requires a high degree of analysis. Alternatively stated, that approach would be this, which is the most common way we think about Bayes' reasoning, or Bayes' theorem. We have a set of pretest odds, we multiply it by a likelihood ratio or set of likelihood ratios, and we arrive at a post-test odds. Now, even still, that involves some math, and that's not always super intuitive to do. So a lot of us use shortcut Bayesian-like reasoning or Bayesian-LITE reasoning, which is more of a system 1 approach. We start with an estimated pretest probability, we look at a set of patient data, and we start to refine that probability, and then we revisit our post-test probability. And we're doing a lot of that intuitively, reflexively. Now again, that's efficient, but sometimes it's prone to bias if we don't know what the pretest probability is, for example, or if we overestimate the pretest probability because we think we know how likely the disease is. So let's take a case and sort of dissect this a little bit more, right? I have an 84-year-old woman with multiple major risk factors for coronary disease presenting with exertional chest pain for the last 3 to 4 weeks. Her episodes of pain are becoming more frequent, and the question is, does she have symptomatic coronary disease? Now, if I was a normative reasoner, if I was a pure Bayist, if I was using only system 2, here's what I would do. I would start with an incidence prevalence of symptomatic coronary disease in women of her age, and I convert it to odds. I can do that here, right? The probability at this step would now be 20% or an odds of 1 to 4. And I determine that by looking at PubMed for an article on prevalence of coronary disease in a population. Now I would start to examine historical features of chest pain in the case and use likelihood ratios. That's the next step in the evaluation here. So I take this pretest odds of 1 to 4, and now I have likelihood ratios for different things. So if the chest pain is described as pressure, that's a likelihood ratio of 1.3. If it's associated with diaphoresis, it's a likelihood ratio of 1.8. But if there's an inframammary location to the pain and there's no radiation, that's a likelihood ratio of 0.8. It starts to decrease my probability. And I got this information by looking at a table of likelihood ratios for various chest pain characteristics in a test book. And I could do the same thing with physical findings. But now I'm not so sure of my physical exam, right? So even though the negative likelihood ratio for reproducible chest wall pain is 0.3, I may not be totally sure that that pain is present. So now I've already started to ruin my math. And even if you take my uncertainty aside, you'd recognize that this type of reasoning has a very high intrinsic load. The sheer number of calculations that are required to perform true Bayesian analysis is a major limitation to using this type of reasoning practically, right? So while this is helpful, this is by the book, this helps me firmly establish disease probabilities, it is very labor intensive. So what if I took a different approach? And actually, let's change the case a little bit. Now I know she has a 30-pack year smoking history, hyperlipidemia, and she actually has known previous non-obstructive coronary disease on a cath from 10 years ago. Should we test for coronary disease with a nuclear stress test? And here, practically, I might use a pseudo-Bayesian approach, right? I might try to use some system 1 and some system 2. So I might have to start with assuming some arbitrary probability of symptomatic coronary artery disease if I don't want to look up the prevalence in PubMed. And let's say, based on this patient, because I know all this other stuff about her, that she has a history of non-obstructive coronary disease, I have a pretty high probability that obstructive coronary disease is causing her symptoms to begin with. Let's say it's 90% before I even order the stress test. And I'm basing that just on the limited history I've gotten and knowing that she's had previous non-obstructive coronary disease. Now I can look at some Bayesian stuff, right? I could say a negative stress test in this situation would have a negative likelihood ratio of 0.16 for identifying obstructive coronary disease. But then I might say to myself, hold on, that's not going to be very helpful, right? So if I do the math on this, even with a negative stress test, her probability, post-test probability of having symptomatic coronary disease is still greater than 50%. And I'm not comfortable saying that that's, a good test, right? If it's still greater than 50%, I still think that's likely, right? So often what we're doing in clinical medicine is an even more simplified version of Bayesian analysis, Bayesian-LITE, all system one. And we simply start with a probability of disease that we're going to arbitrarily classify as low, medium, or high. We're going to look at a diagnostic test, and we're going to assess the quality of that diagnostic test. It might be excellent at ruling out, it might be excellent at ruling in, it might do both. And then we're going to get some probability of disease after we've gotten the test. So if we started in the high and we get a so-so test for rule out, we might be still stuck in medium. But if we had an excellent test to rule out, we might actually move into this low probability. If we started low and we get something that is, we might not even bother, but if we got something that was excellent to rule out, we're very clearly in the low range now here, right? So using this Bayesian-LITE approach is a way of sort of using Bayesian principles without having to do all the math. But sometimes the math might actually be helpful, right? Because this stuff will be prone to bias. Like, my probability of disease estimates might be very off. And that's one of the biggest biases that occur in medicine when we're thinking about diagnostic reasoning. So here's some other limitations or other problems with trying to use pure Bayesian reasoning. And this is a question I always get from learners. How do I determine pretest probability? In other words, what's the base rate? Again, this base rate errors are a major source of cognitive bias, which we'll see in the next talk. But if I'm trying to determine my pretest probability, it's actually very difficult. Now, the system 2 approach would be to actually look for epidemiologic data and use risk calculators. And you can do that for some diseases, but for some diseases you really can't do it well. The system 1 approach would just base my estimates on clinical experience, the context, the care setting I usually see patients in. So in my ER, yeah, we see a lot of acute myocardial infarctions, sure, of course. So my, the pretest probability is already modest, right? Or I might just use my own arbitrary impulses. So for some diseases, we have good, data on the epidemiology, but we don't always know for that patient, like what is the actual pretest probability for that patient, right? So even if we know epidemiologically, there's already some other things that are going to influence the pretest probability, something about their history, something about their past medical history. So it's this inability to precisely establish a pretest probability that is the other major limitation of Bayes' theorem, right? It's very difficult to pin down what this pretest probability actually is. So let's do that with another case, right? So here's a 54-year-old man who's been having frequent episodes of diaphoresis and palpitations. And he's had an erratic control of his blood pressure, but admits to poor medication adherence. He has borderline evidence of LVH and an ECG, and I'm seeing him in the clinic with a student, and the student said, you know what? He's having this diaphoresis and palpitation, his blood pressure's all over the place. Maybe he's got a pheochromocytoma. And I'd say, wow, you've been studying for boards too much. We almost never see pheochromocytomas. And I can even reference something like up to date and say, hey, look, young student, this pheochromocytoma thing is very rare. It occurs in less than 0.2% of patients with hypertension, and the annual incidence in the population is less than 1 per 100,000 person years. This is so extremely rare. How could you even be thinking about this? But then that student might be a student and say, hold on, the flip side of that is that rare diagnoses are always going to have a low pretest probability of disease. And the reason I thought of pheo is because there were other things about this case that are kind of unusual, right? He's got this diaphoresis, he's got this palpitations, he's got this erratic blood pressure control. So then I might say, okay, well, I guess we should start to think about it. And I'd say, okay, it's uncommon, but at least there are tests with excellent performance characteristics that I can use to start to determine whether or not this is likely or not. So if I do 24-hour urine catecholamine testing, these likely ratios are off the roof, right? These are going to be pretty good tests. So even if I have a rare diagnosis, I can start to get a better sense of the probability. However, I still have an inability to precisely establish the pretest probability. Again, it's a major limitation of Bayes' theorem. So I don't know where to assign this guy's pretest probability. If you said 0.2% of all patients with hypertension have this, well, I'm going to be way down here. If you said, well, let's give him some bonus points because he's got diaphoresis and palpitation, maybe I'm going to make him 1%. Or if you said all of these things in the erratic blood pressure control and the LVH, and oh, by the way, he had an incidental CT finding a few years ago of an adrenal adenoma, well, maybe now I'm closer to 10%. And depending where I assign this pretest probability, I'm going to have very different results if I get a positive or negative result. So if I get a positive result on the 24-hour urine catecholamine test, and I said my pretest probability is 10%, well, now I'm almost certain he's got pheochromocytoma, right? But if I said it was only 1%, it's going to be somewhere in this 30-40% range. It's still equivocal. And if I said it was way down here at 0.2%, even if I get a positive test result, well, I still only have like a 5 to 10% chance of this being a pheochromocytoma. And again, I'm kind of stuck because rare diagnoses are always going to have a low pretest probability of disease. So if we never thought about them, we never tested for them, we're never actually going to catch the patients that have pheochromocytoma. And we probably should catch those people, right? If we take out that tumor, they're going to have better health outcomes. So if you were a pure Bayesian person, you're going to say, well, rare diagnoses, are always going to fall flat here in these Bayesian approaches. But sometimes we ought to check for them. So that's another downfall of using purely Bayesian reasoning. So then you're wondering, when should I actually use this? When should I actually teach this? Well, here's when I think it's helpful. We should use analytical reasoning when we have pretest probabilities that are discrete or easily estimable. So if we have a well-established prevalence in a population, or we have risk calculators that can tell us those prevalences in populations, then I think it's an appropriate time to use Bayesian reasoning. When we have limited data points that have clear diagnostic test performance test characteristics. So, for example, we have a clinical prediction rule that has very good likelihood ratios, or if we have a test like a urine catecholamines that the likelihood ratios are extremely strong, then it's appropriate to use Bayesian reasoning, right? We can start to at least get a sense of pretest probability, and we can apply these likelihood ratios and get a better sense of post-test probability. And ultimately, I think these are clinical scenarios when we're faced with a dichotomous question. We have a diagnosis in mind, and we're just trying to establish, is that the diagnosis or not? Particularly for relatively common disorders, like, is this coronary disease? We have excellent data on the diagnostic test performance characteristics of things like stress tests. So when we're faced with this dichotomous question of, is this CAD or not, Bayesian reasoning can be very helpful. So here are some other examples. Clinical scoring rules are a great example of this. When we're using a PERT rule to establish whether or not somebody might have PE, when we're using an Alvarado score to determine whether or not they might have appendicitis, or Ottawa ankle or knee rules to determine whether or not to get imaging, center criteria for group A strep pharyngitis. There are some other cases I think we can extrapolate, right? So again, cardiac stress testing for whether or not somebody's got coronary disease, ANAs for whether or not somebody has lupus. These are things that have well-established test performance characteristics. Now, even though they're imperfect, and even though we may not be able to clearly define the pretest probability, we have pretty good diagnostic tests that can help us, refine diagnostic probabilities. Now, even in deciding to consider these diagnoses considers a certain unquantifiable pretest probability of disease. So whoever said that sensitivity and specificity are not dependent on the prevalence of disease in the population are somewhat wrong, because when these things are studied in populations, there is already a baseline prevalence. There's something special about these patients that they're included in these diagnostic test observational studies that is going to maybe be different. So if we start applying these principles to patients in whom you would never consider the diagnosis in the first place, well, that's where Bayesian reasoning starts to break down again. So how should one teach with Bayesian principles? First, I think I don't have it up here, but I think it's helpful to go through the math in some of these scenarios to really, teach normative reasoning and help learners recognize why normative reasoning ideally is the way we should reason, and why, our descriptive forms of reasoning like script alignment are not always perfect. Here are some other reasons to teach Bayesian, or other ways to teach with Bayesian principles. We can frame diagnostic test interpretation in the context of pretest probability and test performance characteristics. In other words, we're not just ordering tests blindly. We know that there is a positive and a negative likelihood ratio with any test that helps us understand how to interpret it. We can teach test performance characteristics. We should be, right? We shouldn't just be ordering tests. We should understand how they refine our diagnostic probabilities. I think when we're teaching with Bayesian principles, I think it's important to acknowledge that there is bias and arbitrariness in assigning pretest probabilities. Sometimes we're just making these things up based on our own clinical experiences and whims. And again, I think we can use Bayesian principles to improve illness scripts. So if we can show likelihood ratios for things like our Koenig and Brudzinski sign, we'd say, hey, this is why these things don't belong in your meningitis script. Or if we show learners that the likelihood ratios for urine eosinophils and acute interstitial nephritis are basically 1, they're totally worthless, we can say your illness script for acute interstitial nephritis should not have urine eosinophils. So we can start to use these Bayesian principles to improve the other types of reasoning that we're doing.